Those of you who don't have seats, we're trying to put some more chairs in for you. So there may be minor disruptions while chairs land. And don't take my seat, please. Good afternoon. I'm Diane Martindale, this year's president of the League of Women Voters of the San Juan Islands. The League is pleased to be here, and we thank those who made it possible. Would everybody in the audience who's a League member just raise your hand?
Wow.
Okay, thank you. The League of Women Voters does not endorse candidates or political parties, but does encourage informed and active civil engagement. We work to increase understanding of major public policy issues, influence public policy through education and advocacy, and do take stands on issues after study and consensus. If you are interested in learning more, I would encourage you to pick up some of the League's information available here this afternoon at the table that looks like it's out in the hallway now. We're going to pass a little donation basket around. We do have to pay rent on buildings, so even quarters and dollar bills are welcome. This session today is being taped by Tom, and it will be available on channel sjmedia.org. I have 3 announcements.
Website.
Please stop at the back table and look at the ballot initiative I-594 to require criminal background checks on gun sales. And if you feel strongly about that issue, please take a petition and go and gather more signatures. Today is the last day for comments on the coal terminal on the Columbia River. And you can find, just put coal terminal Columbia River online and you'll get there. Today is the last day to reserve a seat for you and your guests at our annual holiday luncheon. It will be held at the Brickworks on Monday, December 2nd from 11:30 to 2 p.m. The cost is $28 and is catered by Coho Restaurant. Our speaker will be Boyd Pratt, addressing the various phases of the politics of food. We will also have a silent auction of scrumptious baked goods, saving you all your holiday baking. Dinner for 8 with wine cooked and served by the board members, some of whom are exceedingly good cooks. So see Claire and Steve at the back of the room. Does something crumble?
Your money box.
Oh, okay. I would like to introduce Sarah Crosby, our programs chair, to guide this afternoon's presentations. Thank you for joining us.
Sorry about that. Thank you, Diane. And for me, welcome to all of you. Thank you for taking the time to come and hear what our speakers have to say today. Our talk for today is entitled Controversy and Clarity, Healthcare and Religious Institutions in Washington State. The purpose of this meeting is to separate fact from fiction as our community becomes increasingly aware of the degree to which healthcare in our state is being influenced by religious organizations. The catalyst for this discussion is the recent signing of a 50-year contract between our hospital board and Peace Health, a religiously affiliated healthcare corporation. This meeting is not about Peace Health, however, as the issue is broader than our individual circumstances, and it is the broader issues that we wish to consider. Our state constitution specifically addresses the issue of public funds being used to support religious organizations. Yet according to statewide media, soon over 50% of hospital beds will be offered by healthcare organizations with religious affiliations. Similar trends are evident throughout the United States. How did this come to be? Is the public being sufficiently informed of this trend? Do they accept the possible ramifications of such a trend? And what are the ramifications? Do our citizens have access to the health care which our laws allow? Our league felt that a discussion of these issues by people engaged with them every day would be of value to our own ongoing community dialogue. The state and national leagues have positions on the separation of church and state, as well as on access to women's reproductive health care. In view of these positions and our growing awareness of developments in the healthcare field, including the Affordable Care Act, we felt that our own ongoing education would be served by this discussion. League positions are created after a careful process that is applied to all of our advocacy. Briefly, once a league has decided to study an issue, all aspects of the subject as defined are researched extensively and then presented to the membership. After study and discussion, a position is then developed from a consensus of the membership. It is only after the grassroots process that league advocacy moves forward. We are not here today to advocate, but to inform and expand our knowledge about some of the issues involved in healthcare in our state. And now to our program. Each of our participants will have from 5 to 10 minutes to speak about these issues from their perspective. After that, we will open the discussion to questions from the audience. We are asking for your questions in written form so as to avoid duplication and pontification. The questions may be directed to one, yes, we have a record of that in this item. The questions may be directed to one or all of the speakers. If directed to one, once his or her answer is offered, other panelists may comment if they desire. If you have a question, just ask. Please write it down and hand it to Ann Jarrell, who will give it to me to read. And Ann, would you identify yourself? She's at the back right now with pads and pens. Our speakers today are Cynthia Stewart, who is a League of Women Voters of Washington lobbyist in Olympia on health care issues as well as transportation. Monica Harrington is an activist in the realm of religious restrictions on health care. David Miller is president of the Greater Seattle chapter of Americans United for the Separation of Church and State. And Jeff Merrow is executive director of the Association of Washington Public Hospital Districts. We are grateful to our panelists who have come great distances in some cases to give you their informed perspective on the topic we are presenting. We ask them because they have particular expertise on the issues at hand. Cynthia is conversant with league positions on access to health care, women's reproductive health care, and she's also knowledgeable about the state's Death with Dignity law as well as with the workings of our legislature. Monica works at the state and national levels with several organizations raising awareness of both the public and of our elected officials on the subjects of religious institutions and their growing influence in healthcare in our country. David works on the broader constitutional challenges brought about by these issues, and Jeff, whose participation was suggested by our hospital board chair, sees daily the challenges with which public hospital districts must contend in meeting the demands of health care for their communities in the face of a bad economy and cuts in government funding. It is our hope that the presentation and discussion which follows will make more clear to us all the issues which have arisen and the complexity of their resolution. And with that, we're going to begin our program. Cynthia?
Thank you. I'm assuming that you prefer for us to stand up as we speak. Is that okay? All right. Okay, thank you. And if you cannot hear me, please let me know. So thank you very much, Sarah. It's a pleasure to be here. Again, my name is Cynthia Stewart. I am on the State League of Women Voters Board. I'm a new member, and I've been lobbying for about 3 or 4 years on health care. I'm actually not the primary lobbyist on health care, but I know a little bit about it. And Susan Eidenschink, whom I support, wasn't able to come today, so it's an honor to be here. I had a sailboat up here for about 20 years, so it's a total pleasure to come back. So, a little bit more about the League of Women Voters and where our positions come from. Sarah talked about the extensive study involved and analysis. That includes a lot of analysis, and it's intended to be very, very neutral. The positions are then developed out of discussion among the league members at all levels. For example, if it's a state issue, all the leagues in the state take up the discussion and submit their recommended consensus positions, and then the state board adopts a final position based on that. We can lobby using the national positions, the state positions. We cannot lobby at the state legislature using local positions. So that's one additional clarification. And sometimes what we have is an opportunity for league members to come to a state convention and offer a resolution. And in this case, we had a resolution from this area asking that we work on this issue, and so we will be doing that. So how do league positions apply to this issue? I guess the first one, and I think the foremost one for me, is that our league position on healthcare is that citizens must have access to quality healthcare at affordable rates. And based on that position, we were very, very active at the national and the state level on implementation of the Affordable Care Act. First the adoption of it, and then the implementation here at the state level. Our position actually supports a single-payer healthcare system, but this was the best we could do. So, and I know that that's controversial, but I'm just laying it out there because I think that the issue of access is really huge. Secondly, we do have a position in favor of allowing abortion for those women who need such services, and that is a national position again as well as a state level position. We have a position on reproductive parity, which means that if an insurance provider allows maternity services, then abortion should be allowed and covered as well. Our lobbyist for the league has been working on that issue for many years, and still we have not gotten a law through the state legislature on that, but we do have a position supporting that. And then finally, the league does not have a specific position on the Death with Dignity Act, and so that is not something that I can speak about from a league perspective. I will tell you that my dad is one of the people that started pushing that decades and decades and decades ago, and I'm pretty old, so it's been a while, so I know a little bit about that. I think the thing that's coming is with the changing economy and with the new requirements for healthcare, we are bound to see a lot of organizational shifts and movement having to do with creating efficiencies, having to do with creating broader systems of care and not just isolated care providers. And from that perspective, the league in its position related to access to affordable quality health care supports those kinds of things. But our principles also say that it's imperative that that abortion services be allowed. And so one of the things we'll be looking at as the system begins to move and change, and it's already, as Sarah pointed out, changing quite a bit, but as that progresses, we will be watching out to make sure that women still have access to the services that they need. And as far as the separation of church and state, I just want to say that my personal read on what's changing here has to do with the obligations of the health district as much as the obligations of Peace Health. And so while we're not here to talk about Peace Health, I think the whole issue of how a public entity contracts for services and what services and how they pay for it and how people get access, that's a huge, complicated issue, and one that the league will actually continue to be involved in. I'm not going to say more about those because I know the other speakers are. So thank you very much for the opportunity to talk about the league and for the opportunity to be here. I'll pass it to Monica.
So thank you, first of all, to the league and to the Sarah and the other panelists and everybody who came out. So my name is Monica Harrington, and I'm the co-chair of Washington Women for Choice. I'm a former technology executive, and perhaps most importantly, I'm the 8th born child of very Irish Catholic parents. It's hard to get more Catholic than my upbringing. I went to Catholic school, attended Mass regularly. Priests and nuns and Catholic politics were a regular part of my childhood. Mom was head of the Altar Society and volunteered at the parish school. My father taught law at a Catholic university and offered pro bono services for over 50 years to members of our parish and the Catholic Church. My parents were also pragmatists. Mom was quietly pro-choice because she knew women who died from botched abortions. My father wrote Oregon's no-fault divorce law because he knew that when divorce isn't an option, people suffer, and especially children. My parents loved their church, but they saw very clearly how blind church leaders could be to the everyday concerns of real people. We talked about the church and its failings often. For a variety of reasons, I left the church as soon as I could. When I was in my early 20s, my oldest sister's best friend, newly pregnant and diagnosed with cancer, died after the doctors in the Catholic hospital she entered refused to terminate her pregnancy so she could start chemotherapy. That was 10 years after Roe v. Wade, and it made a strong impression. I had a long career in high tech and with some high-profile nonprofits, but took up this cause when I heard that my own doctor at Swedish down in Seattle was becoming part of the Catholic system. I knew what it meant. I became even more active when I heard that the Archbishop in Seattle had requested that Peace Health quit doing lab tests for Planned Parenthood patients. It was then that I asked to review the Peace Health contract with the hospital district, and I asked the American Civil Liberties Union to take a look at it as well. I couldn't believe the agreement was legal or constitutional. The attorneys I talked to agreed. Over the past year, I've met with many people who are concerned about the issue, and a brief senior public officials, corporate executives, and journalists, both locally and nationally. I'm currently working alongside a coalition of activists that includes people from Planned Parenthood, the National Women's Law Center, Compassion and Choices, NARAL, the ACLU, PFLAG, Legal Voice, and several other groups. Over the past few years, we've all seen how the conservative Catholic bishops here in Washington State and across the nation are continuing to aggressively drive forward their agenda, which involves moving women's health backwards and depriving patients of their rights, all on the taxpayer dime. Nuns used to run Catholic hospitals, and they often but quietly stood up to the bishops, but the nuns are dying out. The average age of the nuns is over 70, and younger nuns and postulants have become an endangered species. Highly compensated CEOs now run Catholic hospitals and Catholic health systems. Nancy Steiger makes more than $600,000, Alan Yorty makes more than $1 million, and the recently departed CEO of Providence down in Seattle was paid $6.4 million in one of his final years. These highly paid CEOs know that in order to keep their jobs, they have to keep the bishops very happy, which involves depriving patients of their rights and using public tax dollars to expand Catholic healthcare ministries. Let's be clear, when the bishops run things, patients suffer. Physicians are forced to compromise their professional ethics. Recently, 2 pregnant women in crisis were traumatized here in Washington State and put at risk unnecessarily because a Catholic healthcare system prioritized the edicts of the bishops over their health. And the bishops are only getting more assertive and aggressive. Just last week, they said they would never, ever compromise with the U.S. government on rules that enable people who work at Catholic hospitals to get contraception through their insurance plans. The bottom line is that the bishop's rules, when imposed on society at large, are incompatible with a multicultural democratic society. We live in a country where 100% of the Catholic bishops supported a decision to deny an abortion to save a woman's life. We live in a state where almost half our health system is already under the bishop's control. And the bishop who oversees the hospital here has been tasked by the Vatican with bringing the nuns that remain into line. It's within this context that the hospital district commissioners here seem to believe that the issues related to religious oversight are manageable over 50 years. that even though they derive their taxing authority from the state, the Reproductive Privacy Act and the Constitution don't apply, and they're under no obligation to support services for pregnant women or new mothers on an equal basis to other islanders. I disagree, and I speak with physicians and legal experts who disagree too. I hope the formal opinion of the Attorney General would prod the hospital district commissioners to move forward on a different path, but it hasn't. So here we are, potentially on the precipice of a costly, historic battle, locally and statewide, to preserve our constitutional rights and protect patient health from the oversight and control of deeply conservative Catholic bishops.
Thank you, Monica. David?
Thank you, Sarah. I didn't write any notes, so I'm going to read my comments, if you don't mind. As our mission statement says, Americans United for Separation of Church and State is dedicated to preserving the constitutional principle of church-state separation as the only way to ensure religious freedom for all. We believe our nation's founders were fully aware of the implications when they included the religion clause in the First Amendment to the United States Constitution. This clause states, quote, Congress shall make no law respecting an establishment of religion or prohibiting the free exercise thereof. Among other things, this means that government should not use its lawmaking, enforcement, or taxing powers in furtherance of any religious goal or theology. As Thomas Jefferson said, religious institutions that use government power in support of themselves and force their views on persons of other faiths or no faith undermine all our civil rights. Moreover, state support of an established religion tends to make the clergy unresponsive to their own people and leads to corruption within religion itself. Erecting the wall of separation between church and state, therefore, is absolutely essential in a free society. In Limon versus Kurtzman in 1971, the Supreme Court pronounced a three-pronged test to determine if government law or action is consistent with the religion clause. 1. It must have a secular purpose. 2. Its principal or primary effect must neither advance nor inhibit religion. 3. It must not foster excessive entanglement between government and religion. Courts generally have held that this wall of separation between church and state extends to the use of taxpayer dollars to fund activities that are partly or wholly religious in nature. What does this have to do with the issue of hospital mergers in Washington State, or more specifically the operation of the Peace Island Hospital here on San Juan Island? I'm no expert on the history of this hospital and the reasons for its construction and operation by a Catholic healthcare organization. Nor do I want to question the motives of Peace Health and its stated mission of carrying on, quote, the healing mission of Jesus Christ by promoting personal and community health, relieving pain and suffering, and treating each person in a loving and caring way. I have no cause to question Peace Health's sincerity in that mission. Sincerity aside, however, we at Americans United have serious reservations about tax support for a healthcare organization where legal medically appropriate services may be denied because of religious doctrine. This September, for instance, Americans United challenged the proposed merger in Texas between two public hospitals and Seton Healthcare Family, a Catholic-run institution that answers to the Church's theology. Americans United stressed that while courts have approved the allocation of government funds to certain religious hospitals, they have emphasized that the care provided by those hospitals could not be controlled by religious authorities and could not discriminate based on religious teachings. In a letter to Central Health, the operator of the two public hospitals, our attorney said, Central Health can contract with Seton to provide secular services, but it cannot bind itself or any other government entity to comply with religious dogma. The great majority of recent and proposed hospital mergers in Washington State involve Catholic healthcare organizations, Peace Health, Providence Health and Services, and Franciscan Health System. All these organizations follow the ethical and religious directives for Catholic healthcare services of the U.S. Conference of Catholic Bishops. Publicly funded religious healthcare organizations are extremely problematic from a constitutional point of view. I've already referenced the First Amendment to the United States Constitution. Now I'll reference the state of Washington's Constitution, which states that no money or property shall be used to support any religious establishment. Now, Peace Health describes itself as a healthcare ministry and follows the aforementioned bishop's directives. Among many other items, these directives state that, quote, the faith that inspires Catholic healthcare guides medical decisions, and also that provision of the sacraments is an especially important part of Catholic healthcare ministry. These directives also give the local bishop final say over partnerships with non-Catholic healthcare institutions. Then, of course, there are the specific directives that prohibit certain procedures or the provision of certain information or referrals, most especially but not exclusively concerning reproductive health and end-of-life care. In an August letter, Washington's Attorney General stated that public health districts may not administer or fund programs to provide maternity care benefits, services, or information to women without also making provision for the rights secured under the Reproductive Privacy Act. The basic question is this: are San Juan residents receiving all the legal, medically appropriate services they would expect from a publicly funded hospital without any interference from religious doctrine?
David, I'm going to have to stop
Yes.
you there.
Okay.
That's about 10 minutes. But thank you so much for your comments. And now, Jeff?
Well, I encourage those of you who have got questions, stand up. Yeah, okay, thank you. Encourage those of you who have questions for the previous speaker to find one of those notepads and pencils and write them down. And I suspect we're going to have time to get into a conversation, although it's great to see so many people here. So thanks for coming and thanks for getting engaged. Again, my name is Jeff Muro. I've worked on behalf of the hospitals in Washington State for 30 years, long time. Had the opportunity to represent the hospitals twice with regard to state initiatives on death with dignity. Organization changed its position between those two initiatives, so I got to argue both sides of that. First time I was on Pat Buchanan's side, my mother didn't talk to me for a month. Second time turned out better for me. It is a great pleasure for me to be with you all, and I really want to thank each of you for finding time to get invested and to get smarter about these issues. They are really, really important. And they carry enormous implications for the way that we will work and live and heal and be healthy together for a long time. So thanks to each of you for deciding to get smarter about this. And I want to encourage you to get smarter. There's a fair amount to read here. The issues are complicated. And part of the reason that I found my way into this work and have continued to do it for as long as I have is that I love puzzles. And this is a great puzzle. Our lobbyist in Olympia has made the observation that what makes this a fun issue for all of us down there is that you've got two sides that are intractably opposed, but you can't say either one of them's wrong. It's hard to argue against religious freedom. We heard earlier that the U.S. Constitution protects it. It is also hard to argue about those religious values being pushed on people who don't accept them. So We are here today to begin to explore a little bit about that. I've got 3 or 4 points to make, and I'll try to go quickly. First, I want to talk for a minute about public hospital districts in the state of Washington. They cover 75% of the state's geography, and they handle about 20% of the state's people. So they're an important part of our delivery system. They became an important part of our delivery system in the early 1960s. What happened in the early 1960s? A whole bunch of organizations, most of them religious, found they couldn't support hospitals anymore. And so a whole bunch of communities in Washington state that had a religious hospital suddenly found that the only way they were going to keep a hospital was to create a public hospital district and begin to pay property taxes to do it. So we now have 58 public hospital districts in the state of Washington. 43 of them operate hospitals. So there are a number of public hospital districts that don't operate a hospital, don't have a hospital within their territory. You folks used to have one of those. There was a public hospital district here for years before anybody decided it would be a good idea to build a hospital. So about a third of our public hospital districts fall into that category. They don't have a hospital at all. Of the ones that operate hospitals, about half or a little bit more regularly provide routine births. So there are about 25 public hospital districts in the state that regularly provide routine births. The balance don't. They tend to be in really small communities where it is really difficult to attract the kind of clinical expertise you need to provide births safely. Pacific County hasn't had an elective birth since 1980. Pacific County is the county that's just north of Astoria. So when you come over the Columbia River, they're over that beautiful bridge, and you drive into that part of our state, that's Pacific County. They haven't had an OB service there for almost 35 years. So there are parts of this state where not just access to abortion services, not just access to the kind of services that are at risk here, tubal ligations, vasectomy, and so forth. They haven't had access to maternity services locally for a long time. And there are many other parts of the state that suffer that same challenge and have for a long time. So I think with that, I'm going to move into my second point. I'm going to talk for just a minute about this constitutional issue, and I think it's something that we want to get into more as we get into the debate. I do want to encourage you to go ahead and find the Washington State Constitution and look for Article 1 and read Section 11. It's not very hard to read, and it's pretty straightforward. You do have to think about what the words mean, and this is what I mean about getting smarter. We're headed to the courts eventually. It's going to be some group of judges somewhere that decide what the answer is to these questions. And whether that happens in a month or in a year or in a decade, they're not going to get answered clearly any other way, and oftentimes even when the judges have had their say, it still isn't clear what they said. But our Constitution is pretty clear. No public money or property shall be appropriated or applied for religious worship, the exercise of instruction, or the support of any religious establishment. So two-part test. Is there public money involved, and is it being used to support a religious purpose? So the first part, I think, here and in the other public hospital districts, by and large, that have affiliated with Catholic healthcare organizations in our state, the answer to the first part of the test is yes. There's public money that is flowing. Then you come to the second part. Is it being used for religious purpose? And this is where the courts likely will have to reach a determination. I will say that we had the opportunity, my wife is here with me, we had the opportunity this morning to drive up and visit your beautiful new hospital. The only resemblance it bore to a church to me is that there was about the same amount of noise in each side, inside each. Other than that, it didn't feel very much like it was a religious place to me. It didn't appear that there was a lot of religious instruction happening. It didn't appear that there was a lot of religious education going on. And when the justices look to the constitutional test, they're going to look to those words. That's why I want to encourage you who are interested in this to look at the words. Look at what they say. It's not that hard to understand what the judges are going to be doing, if you take the time to get educated. Now, we can change the Constitution. We can change state law. But if you look at the pure language, it'll be up to the judges to decide is what's happening, if somebody brings this case, is what's happening here, is what's happening in one of the other public hospital districts where the hospital is now being operated by a Catholic enterprise. Is that a religious experience? Is that religious instruction? Is it a religious activity? And as our previous speaker said, Peace Health characterizes what it does as a ministry. So the judges have some questions to answer here, and I think it's hard to answer them otherwise. Attorney General's opinion was referenced a little bit earlier. I'm just going to speak to it briefly, and I hope we get some questions about it. The Attorney General's opinion, I thought, did a really good job of saying what it answered and what it didn't answer. It said public hospital districts are subject to state law. They're public entities operated under the municipal corporation of the state. To the degree that we've got a law that binds state, it binds public hospital districts. As was read earlier, what we say about that is that the state, to the degree that it administers or funds programs related to maternity services, falls under the guidelines of the Reproductive Health Act. So to the degree that we have a public entity that is administering maternity services or funding them, they're subject to the full brunt of state law. State Attorney General said, I'm not going to speak to what a maternity service is. I'm not defining that with this opinion. I'm not going to define what it means to provide it. I'm simply going to say public hospital districts are state entities, they're subject to the state law. Now, finally, I do want to take just one more minute, Sarah, and I appreciate your patience with me. Thank you. I want to take one more minute, and I do appreciate I've had longer than anybody else, and I appreciate that, so thank you. I do want to make just one more point in closing, and that is that I don't want to minimize the importance of the issue here. There are important questions at risk. I think that some of the important questions are being put in the wrong hole, but I don't want to minimize the fact that these are critical issues and critical questions. The voters of the state of Washington have said women ought to have access to a full range of reproductive health services, including abortion services. The voters of the state of Washington have said, if I reach a stage in my life where I can find two doctors who don't know me, look at my records and say, I'd be surprised if this person was alive in 6 months. I have the right to seek for the means to end my own life. We voted for that. There may be a whole bunch of people who disagree. Fortunately, they're not required. It's simply an option. Our organization, the State Hospital Association, has worked for 50 years to promote access to care. We want to make sure that people have access to services. We are dedicated to ensuring that people have access to the services they need.
Jeff?
Good. The challenge we will face here, in my opinion, the challenge we'll face here, in my opinion, is when, in fact, local practitioners begin to feel bound up, begin to feel that their practice is being limited, begin to feel that their clinical freedom is being limited. When that happens, and it will, we're going to have large issues around the state.
Jeff, could we stop
Thanks.
there?
Yes.
Thank you. All right, thank you all for your comments. I'm sure we are going to have a number of questions directed to each of you. Do we have some to begin from the audience?
You want them written, Sarah?
Yeah, they want
Yes, I
them,
do.
Well, here's some.
they want them written legibly.
Okay, we're coming.
I suppose it's for Jeff, but it could be for anybody.
Audra, if you could pass that over to Ann so that I could read it, since I have a microphone, that would be helpful. While we're getting some questions forward, perhaps, Jeff, you could speak to this. What is the extent, to your knowledge in the state, of how other hospital districts are dealing with let's not specify the Catholic Church. Let's talk about religious institutions, because there are, am I correct, other religious affiliations of hospitals.
There are some, but there's not many. What we really are here talking about is a Catholic phenomenon. And I would say that hospitals are getting more sensitized to these issues as a result of the discussion and the activity here in this part of the state. We have public hospital districts on the eastern side of the state who have been aligned with the Sisters of Providence for decades. And there hasn't been much noise about that. There hasn't been much concern raised about it. But I think that the work that has been done here by those of you who are concerned has really raised the issue and raised the temperature of the issue considerably. I think that what public hospital districts and other entities are doing now is trying to consider pretty carefully what can we do. You know, the Skagit Valley Hospital effort to develop a contract with Peace Health that won't bind them to the ethical directives is an example of the kind of change that we're seeing. Is it going to be possible for them to have a contract that doesn't bind them to the ethical directives? I don't know if it will be or not. It was possible for the folks in Port Townsend to do that. Their agreement doesn't include, in fact, specifically prohibits the use of those directives to limit clinical decision-making in Port Townsend. So I think that there's evidence to suggest that raising the issue is causing people to look at it. And I think all sides, at least from where I'm sitting, it appears that on both sides of the negotiating table, on the Catholic side and on the public hospital district side, there's willingness to talk.
Thank you. Would any of our other panelists like to address that?
The one comment that I'll make regarding whether or not physicians are actually facing these restrictions is, I was just at a meeting this last week with, I think there were 50 to 60 OBGYNs and physicians in training, and they're terrified because there are a couple of things that kick in. They're not covered under malpractice insurance if they do something that the Catholic Church finds morally objectionable. They are deeply concerned that their medical decisions are going to be are subject to this review. And when we talk about an elective abortion, what people don't understand is that if you are handling high-risk pregnancies, abortion has to be an option or women will die. And I sent out mail to a broad group of people describing 2 incidents that recently happened in this state where doctors in Catholic hospitals refused to give women the treatment that they should have if they were following their professional, ethical guidelines. So it's not a theoretical problem that may happen, it is happening.
Anyone else? David, there has been a request to allow you to finish your remarks, and I think that we should go forth with that. Why don't you, since you're reading it, why don't you back up one paragraph and then let it rip?
No, I only had like 1 minute left. So let me just say what I was going to finish saying. The final sentence is that the trend is worrisome for those of us who value separation of church and state. And my final comment, it is hardly a positive development when the final decision on what health care services are provided may rest not with medical professionals, patients, or even governmental officials, but with a religious leader. That's all I have.
Thank you for that. We are trying to keep this discussion to a broader level. There are questions that have come up about Peace Island Medical Center, but we're here today to talk about what the trends are in our state and across the nation rather than relitigate the Peace Island Medical Center situation. It is emblematic of something that's happening, but it's not the subject of discussion today. I have a question here which I would like to take to a state level. see. I'm going to have to save that and go on to something else. Let's see.
Sarah, I have a state level question. Or it's, at least it's a general question, it's not specific to this island.
All right, that would be good. I have a question here. Why is no one here to speak for Peace Health? The reason no one was invited to speak for Peace Health is that we would like to talk about broader issues. We do not want to get into the weeds of our local discussion. We felt that it would be more fruitful to see what the trends are across the state and across the nation, which will help us all in evaluating what our own situation is and how we talk about it. Thank you. Do any of our panelists know if any initiatives or referenda have been contemplated about the issues that we're talking about today? David?
It's me, I'm not.
No, I'm not picking up the... Okay.
I do know that, can you hear me back there? I know that a friend of mine started a petition and got about 5,000 signatures to go to the governor and the legislature to prohibit any kind of curtailment of medical services for religious reasons. And I also know there was another petition, and maybe Monica can help me here, that was distributed around Seattle Town Hall when I was there, I think with more or less the same purpose. Now, whether they lead to an initiative or a referendum, I don't know. The one petition I know of was going to the governor and the two health committees in the Senate and House legislature. So that's what I know.
Okay. Monica?
And I would say that there are...
Could I ask you all, please, to use the
Sure.
microphone? Thank you.
There are several people who are looking at this issue. I've seen some of the petitions that have been signed. When we're looking at a petition that would, or an initiative that might go on the ballot, that is something that needs to be considered very carefully. There are a bunch of approaches to this. One of them is litigation, because there are several people who believe that we actually have the protections in place in our Constitution and with the Reproductive Privacy Act. But certainly if there's a specific way to fine-tune things, an initiative, lots of people are looking at that process and they want to move carefully and thoughtfully.
Thank you. All right, I have a question here. Is current Catholic policy still to deny abortion services to save a woman's life? If so, can that Catholic pregnant woman go to any doctor that she wants, such as a non-religious doctor, for her abortion? I'm not clear if this person is referring to our situation, but let's just keep it at the broader level, the Catholic level. Okay, Monica.
So what the directives say is that a direct abortion is never allowed. And if you look at the various readings and teachings of the Catholic bishops, they go into this at some length. And the way that they look at it is that if there is an act that directly targets the fetus, that is never allowed under any circumstances, even when a woman will die. So we had a situation in Arizona a few years ago where a nun authorized an abortion to save a woman's life, and the local bishop excommunicated her. And then what was interesting is all of the bishops unanimously supported the local bishop's decision to excommunicate the nun. So there are circumstances where if they're not directly targeting the fetus, they can move forward. So for example, in the case of an ectopic pregnancy, if the doctor says that if your tube is going to explode, basically, we can remove the tube because we're not directly targeting the fetus in that case. We're doing something to save a woman's life. And what that removes from consideration is a less invasive procedure, such as administering a drug like methotrexate. So the problem with these directives is that they, when Catholic institutions follow them very strictly, and Franciscan here in Washington State is the worst in terms of following all of the Catholic directives very strictly. They're hiring an attorney right now to make sure that the directives are enforced throughout their hospitals. That's where we run into real trouble. But the recent cases that I'm aware of and that are going to be shared appropriately with public officials have to do with cases where doctors made a decision. We think they were scared to do what was medically appropriate on behalf of these women. And so in one case, after a woman was seen in a Catholic facility, they told her to go to the UW, which was more than an hour away. She didn't feel strong enough to go. And so she showed up at a medical clinic and was heavily bleeding and was in crisis. And that's the sort of thing that actually is happening in our state now.
Thank you. Did anybody else want to comment on that one? All right, the next question is, what would happen to a religious hospital if the physicians and staff decided not to follow the bishop's directive? David? Or Jeff?
I really have no idea, but I'm going to assume that there are probably quite a few physicians who quietly don't follow them, at least in terms of whispering under the table about what some of the alternatives might be or referrals, but I doubt that I personally doubt that they would directly give some kind of medical service that would be easily traceable back to them that would violate the directives. But I don't know this for a fact, but that's kind of the rumors I've heard, and maybe someone else knows better.
Well, in some, you cannot directly confront the bishops. None of the Catholic hospitals can do that. As the nun here said in a public meeting last year, she said, we will never disobey the bishop. And so what's happening is that in some of these Catholic hospitals, they're saying, don't force us to write these rules down, and we'll just deal with them quietly behind the scenes. But that leads to situations like happened at Swedish Hospital, where a woman needed an abortion, and the doctors, her doctors refused to provide an abortion. They said they would go with her to another facility. And later, that was written about in The Stranger. I happen to know the woman involved. Her case was written about in The Stranger, which is a Seattle Weekly magazine, and a lot of people said, well, those doctors just didn't know that they could actually give her an abortion. And it's almost like there's a secret way of doing that. And to me, that's just unacceptable. It's unacceptable that a woman's health should be compromised because there are these secret rules that have to be transmitted in some way that the bishops can't detect. It's just unacceptable.
Jeff, I have a question for you. This says, Washington state law provides that hospital districts can contract with private nonprofits to offer health care services. It is the Court of Appeals and State Supreme Court who interpret the Constitution with respect to state laws. There are no appellate decisions regarding this issue. With so many strong opinions, why have no challenges been brought? David, you might want to chime in on this too.
Well, I think it's a good question, and I think what is happening at the moment is that there are numerous cases where the key thing if you're getting ready to bring a case is to try and make sure that two things are true. One is that the fact set supports the argument you're trying to make, and the second is that you can be reasonably confident that the judges are going to support you when they consider the case. And so you want to be careful about which case you choose to try and make your argument around. And it is my suspicion that there is a fair amount going on at the moment to try and identify a case where it appears that there's a clear violation of the state constitution or public hospital district law. And I'm confident that there will be a case brought soon that tries to untangle some of these issues. I'm also confident that it's going to take a long time for those cases to get resolved.
Thank you.
And Sarah, one other comment about that. One of the things to remember about this is because a couple of people asked me, like, why in the case of these women who very recently ran into trouble, why isn't there a lawsuit happening? And one thing I'd like to remind everybody is that when people run into these situations, they're typically horrific. And emotionally they're draining, physically they're draining, and not only that, but we know that in our society, if a woman steps forward to fiercely say she demanded an abortion and couldn't get one, or she needed an abortion and she couldn't get one, people are going to crawl out of the woodwork to tell her what an evil person she is. And that's one of the issues. So you can bet that the people who are being very thoughtful about this are being thoughtful on behalf of whatever person is going to be the subject of a lawsuit.
Thank you.
And Sarah, if I could just, I'm going to build on that for just a moment here and just, I think that one of the challenges, particularly with the access to reproductive health issues, the access to abortion services, is that we now have an issue where the Catholic organizations are being challenged to give us more than a nod and a wink when they talk about how they're going to pursue this. Most of the time that I was growing up, these services have been about a nod and a wink, whether it was a religious organization or not. So I think that some of the issues here have as much to do with how we as a society think about access to these services as they do with who's supposed to provide them.
I think, too, that we are all taught, once we reach a mature age, that if you are agreeing to something, you should have it in writing. It's the only defense that you have, which is a point that many people in the audience have made over time. Thank you. Is there anyone here who would like to speak to this issue? Why does it seem that only religious hospital groups will go into a small community to keep that small rural hospital open? I think that's a question quite pertinent for us. Let's see.
So,
And this particular questioner cites the Cedro-Woolley Community Hospital, which has apparently assigned an agreement with Peace Health and therefore will be able to continue in service. Would any of you like to address that?
Yeah, Jeff should speak on that.
Yeah, I think so.
So what I'd say about that is that when we look across the country and when we look in our state, it is the religious healthcare systems that are large enough to be looking around for partners and have the kind of cash that makes that kind of partnership look attractive to everybody involved. The effect of aligning with a Catholic health system, if you are a community hospital, is that it gives you access to capital markets, it gives you access to funding for new technology, it can help you build a pretty nice hospital. There are a variety of other things that come your way when you decide that you're willing to align with a larger system. And the truth of the matter, from what I can see, is that we went through a period from about 1995 until about 2005 where almost all of the hospital system growth in the country was taken on by for-profit enterprises. And there was a big hue and cry about that. There were a lot of people who were very unhappy about the fact that for-profit entities were taking over what had been nonprofit or religious community hospitals. So the for-profits now have apparently made all of the acquisition that they want to make. I do think that it's a challenge for organizations like Peace Health who have chosen to move into places like Ilwaco and other remote locations and said, we think part of our ministry is to reach out and ensure access to those communities. I think it is a challenge for them to find their way through the kinds of questions that have come up here. Again, it's a good idea that this debate is happening. I think that a key question is, what might be different if this debate were occurring 2 or 3 or 4 years ago instead of today? And, this is just the way that America works, is that you wait till something begins to boil over and then everybody begins to pay attention. Too many other things happen.
Following up on that, what are the options for hospital ownership, administration, and operation in lieu of religious health organizations?
In our state, not many. There are not very many. Swedish Health Services was growing for a while. In fact, the original contract between the 3 North Olympic Peninsula hospitals, Forks, Port Angeles, and Port Townsend, the contract for those 3 hospital districts was first made with Swedish Health Services when Swedish was growing. Swedish took over what had been a public hospital district in North Seattle, what we call Stevens Healthcare, as well as Ballard, and they bought the Providence Hospital before Providence bought them back. But aside from Swedish, there hasn't been very many nonprofit organizations that have reached out to try to grow. The other option would be to try to encourage the university system to do more than it's doing, and they're sort of looking for public funding as a way to support that work if that's where to go. But at the moment, there's a big push across the country for small hospitals to join with larger hospitals. And in our state at the moment, the large hospitals that are available to do that with are run by Catholic systems.
Sarah, can I?
Sure, go ahead.
So I spoke with some very senior officials at the University of Washington, and essentially we have a political problem. We have an economic problem and we have a political problem. So the Catholic hospital systems are in the best position because they can frankly come into a community and they have a lot of capital and cash. And sometimes the people who are making these decisions are going to benefit from that. And the University of Washington, as an example, cannot go into a community with cash up front. What they can do is they can say, we're going to have a system that's aligned with the University of Washington. It'll have high quality and so forth, but we're not going to come in with that big capital infusion up front. I think what people are seeing here in the community, just from a cost structure standpoint, is that the Catholic systems run a surplus. So they come in with cash, but they also charge quite a bit for their services. So the problem is that people are only evaluating the money on the front end. They're not doing a long-term analysis of the total cost of healthcare. And that's something that needs to happen. I know the University of Washington wanted to go in. They wanted those agreements over in the Skagit area that where Peace Health won one. The University of Washington came in. Virginia Mason was also a contender. But they weren't coming in with the buckets of money. And so we have to think through, do we want to support a stronger public health system with the University of Washington? What can we do to make sure that the person who's got the biggest bucket of money up front isn't the one who gets these deals?
Following up on that, we have a question for anyone in the panel who feels qualified to answer. Why does the Catholic Church get so involved in healthcare? Is it a matter of money, religion, or history? Anybody want to take that one on? Well, no, if Jeff, if you can, why don't you chime in?
Well, I'll just speak to the history issue, and I'm an inveterate storyteller, and I'll make this brief. Every state gets to have 2 statues in the Hall of Statuary in Washington, D.C. A couple of states haven't named their second statue yet. Washington's 2 statues, Marcus Whitman, who founded Whitman County and Whitman College, and Mother Joseph, who was the first Providence nun in our state and founded the first 3 hospitals that were built here. Catholics have been involved in healthcare in Washington state from well before there was a state here. Now, we haven't had the Catholic directives all that time. And I'm not here to talk about what Mother Joseph might have done or didn't do. I'll just say that that tradition has been entwined with state tradition for a long time. One other sort of oddity, and I collect these, but I was with my mother-in-law last night. She's lived on Whidbey Island for a long time. She reminded me that there was a time when the public ferry terminal on Shaw Island was run by nuns. So just a curiosity there around the role of religious in our life.
Sure. Yeah, I think it's really important. I think it's possible to honor the contributions of the nuns and what they did. If you think about it, if you were a Catholic woman 100 years ago, you basically, you had a choice. You could either, because you couldn't have access to contraception, you could get married and have 10, 12, 15 children, as many women did, or you could become a nun. That was the choice for many Catholic women. Many women chose to become nuns, and they did a beautiful job of coming out into the territories and opening up hospitals, in part because Catholics themselves were discriminated against, and they wanted to make sure that there were hospitals that would serve everyone. So I want to be totally clear that what the nuns did was great, was fabulous. They were the original feminists. But times have changed, and the Catholic bishops insist that the core purpose of these institutions now is to provide witness to the Catholic faith. And they view the ownership and control of health systems as a way of imposing their doctrine, which essentially requires adherence to the idea that conception, first of all, that conception begins at fertilization is one, and that you have to go all the way to a natural death, and they define what that is. But they also have directives that have to do with marriage and sex and so on, and they view the health system as a way to impose those directives as well. So, I've been married for 23 years, and I can tell you quite honestly, I've never had sex in a way the bishops would approve.
And we won't take any follow-up questions. Next question. By state law, patient privacy is required. How do religious organizations that run hospitals know when their religious directives are not being followed? Are there ways to completely maintain the privacy of the doctor-patient relationship? Jeff, I think you should speak to that, if you would.
Well, I'll try. I think it goes back to the points that were made earlier, and I think, again, this is where I see the storm clouds brewing. It is in those physicians, and just a little side note here, lost in a lot of the noise around Catholic health systems taking over local hospitals is the fact that in our state, lots of local hospitals have found it necessary to employ local physicians to keep them in town. This is a relatively new phenomena as well. It didn't used to be the case that physicians worked for hospitals. They were independent and in fact valued their independence pretty fiercely. And it's only been in the last 12 or 15 years where we've seen hospitals acquiring physician practices becoming more the norm than the exception in our state. And the result now, I think, is that something more than half of the licensed docs in the state are employed by a healthcare system. As more healthcare systems find themselves governed by the Catholic directives, the clinical independence and the ethical decisions of those practitioners is going to become increasingly challenged. In theory, it is, I think, for most of the healing professions, matter of principle that they're not going to reveal the identity of a patient or the course of treatment that was followed. Patient privacy, patient protection, confidentiality is the ethical standard for being a healthcare professional, physician, nurse, and I suspect a number of others. How that plays out as these issues come more and more to the fore, I think, is where the debate will go. Monica has her arms around a whole bunch of stories where it appears that we're finding clinicians who can't do what they think is in the best interest of their patient. Those are the kinds of issues that are going to drive the discussion into the courts, where ultimately things will get untangled to the degree the judges can untangle them. But in theory, confidentiality is paramount importance to the clinicians.
But they,
Go ahead.
yeah, but one of the really interesting things is, one of the things that's driving all of these consolidations is the need for technology, because we want better record keeping and we want a seamless transfer of patient records from one physician to another. And so the idea that what a physician does stays between a doctor and patient, that's not true. A doctor creates a record for the institution, and what they prescribe becomes part of that record. Now, if you're saying that a doctor is not going to put into the record that a woman has an IUD or that a woman is taking a certain kind of contraceptive, that's dangerous, because a physician who sees her later needs to know that that's what's happened. So this whole idea that there's doctor-patient confidentiality that somehow isn't going to go up the food chain of any of the entity that they work for, I find that, frankly, I find it ridiculous and offensive.
Looks like David.
David,
Monica, I'm not sure if I offended you, but if I did, I'm sorry.
You're in a tough spot.
Jeff, how do other religious-based hospitals, not Catholic, deal with doctrine issues, to your knowledge?
I don't have very much knowledge about that. I don't think that any of the rest of the faiths have as detailed a set of ethical and clinical guidelines as the Conference of Bishops has produced to guide Catholic healthcare ministry.
This is to the panel at large. Have any hospital districts in Washington or nationally jettisoned a Catholic healthcare organization due to their maternity or abortion policies? I know of one in Kentucky.
Yeah, there have been a few. There have been situations where Catholic hospitals have lost their, basically their Catholic identity. There are some situations where deals have fallen apart further down the road because, basically because of an outcry and so on. There are a few of them. There aren't many. Typically, the place where there's an organization called Merger Watch that works out of New York, and they've helped many communities put in restrictions before a deal gets completed. But they also would be the first to say that it's always dangerous to do these deals with Catholic entities because there is a constant pressure to, move closer and closer to to adherence to the bishop's ethical directives.
What was the name of the organization?
Merger Watch.
Merger.
We'll put that up on the easel here.
Sounds like murder.
Oh, yeah. Merger Watch.
Thank you.
Probably for you, Jeff. Doesn't the agreement between a hospital and the hospital district state what the district funds can be used for?
I'm not aware, I don't know what every agreement says. I would say that it is unusual for there to be an agreement that involves the use of public funds, in which the use of those funds isn't pretty clearly described. Because that, I think, is a matter of public record, and it's something that the voters, the property tax, if the taxpayers couldn't figure out where their money was grown.
All right, the next question. How do the Catholic directives address individual advance directives, living will, healthcare proxies, etc., particularly if the advance directives prohibit or limit nutritional hydration medication, do not resuscitate orders? For example, if one's personal directive prohibits nutrition hydration if in an irreversible coma.
So what the Catholic directives say is that they will follow advance directives so long as they don't conflict with Catholic doctrine. The truth is that Catholic hospitals have done a pretty good job of palliative care. What the problem is in a persistent vegetative coma, they don't support death with dignity. They do not allow physicians to participate in that in any way. They also, after the Terry Schiavo case, they came up with a whole new directive. I call it the Terry Schiavo directive, which says that if a patient is in a persistent vegetative coma, they must be given oral nutrition. So you have to be kept on a feeding tube if you're in a persistent vegetative coma, regardless of what your advance directive says. If you are if you're an elderly patient or you are near the end of life, they will allow the withdrawal of a feeding tube if it's clear, like you're on the path to death. But like in the Terry Schiavo case where she could have gone on for many, many more years, you cannot take the feeding tube out.
Are physicians at religious institutions restricted by contract in advising patients about reproductive services and end-of-life aid? Jeff?
I think that the answer to that is in some, but not necessarily all cases, that the contracts that physicians sign are going to call upon them to follow the ethical guidelines and the Catholic directives. So I think we clearly have seen evidence that that's the case with some clinical people across the state, whether it's uniformly the case or if there are ways that physicians can, just as the hospital did in Port Townsend, cross stuff out. Whether the physicians can cross stuff out or not, I'm less aware of. But I know that there are some physicians who have been surprised to find buried in their contract language that suggests they're going to abide by guidelines.
Yeah, I think we could work on contracts to make them possible for people to read, even if it's their very own, they need to read every part of it. Monica?
Yeah, some of them require adherence to all of the directives as a condition of employment. Others require their physicians to adhere to what they call the Statement of Common Values, which is a subset of the directives. But then in other places they'll say they follow all of the ethical and religious directives. So the physicians are really left in a situation where they've got this threat hanging over them all the time that they could be fired. The insurance is written in such a way that if a doctor is doing something that its employer finds morally objectionable, they're not covered. And so what's happening is that the physicians are being basically left out on their own for anything that the Catholic entity decides is immoral.
Anybody want to chime in on that? Somebody would like to know if the Catholic Church is targeting pro-choice states like Washington State and ignoring states like Mississippi for some reason. Does anybody have any anecdotal information about that?
What I know, I was just in conversation with a senator from a southern state, and we were talking about this issue. And she was asking why this is happening in Washington State. Part of it has to do with Washington State and the western states are some of the states where we're seeing this the most. So in Washington State, we're approaching 50%. There are 8 states where the ownership and control of Catholic hospitals is greater than 30%. And many of these are in the West, and part of that had to do with the nuns having come out here and started these hospitals. And it's just a higher concentration. And then ironically, because we are less religious than other states, USA Today once called us the least religious state in the Union, we have a live and let live attitude. And I think people just weren't tracking this. I know that when I got started on this issue, people that I thought were tracking it were paying no attention to it. So it's partially because of the base that we started with, where there were a lot of Catholic hospitals, and then it's just that people here a lot of people didn't even understand what the ethical and religious directives were. And they're all waking up to it now. So
I I just want to interject here for a minute. There have been many fine questions submitted, and I'm going to get through all of them, I think, today. But where your questions are specifically directed to Peace Island Medical Center, I'm going to try and take it to a broader point. Again, I want to stress, we're not here to discuss Peace Island. We're here to discuss religious influence on health care and the issues that that brings up. There is an inquiry about whether doctors at religious-based hospitals, whether or not they're allowed to prescribe contraceptives. Do they see pregnant women? Are they allowed to refer problem pregnancies for abortions? I think this refers to a lot of articles that we've read recently. Would somebody like to take that question?
Sorry, I think the reason that I'm spending so much time answering these questions is I spent the last couple of years really studying and doing the deep dive on this. But there are 3 major systems here in Washington State, and they all follow the directives to different degrees. So Franciscan follows all of the directives all of the time, requires it as a condition of employment. There's no way you can get contraceptives in a Franciscan institution. Providence is less strict, and at least up until now, most of Providence has allowed contraception, but doesn't allow tubal ligation and so forth. So it varies. What we're seeing, and then Peace Health traditionally has been the least restrictive. However, it was Peace Health that wanted to cut off the lab test for Planned Parenthood patients, and that's a recent development. And we are hearing of incidents in the broader Peace Health network. So the issue is that there's a trend toward conservatism. We have 3 very conservative bishops in the state, and ultimately they make the calls. And in fact, Peace Health was going to align itself with Catholic Health Initiatives, and so they are the most strict. So it's, certainly all of us who are watching that development, and Peace Health has said that it wants to work with Catholic Health Initiatives in the future. Catholic Health Initiatives is the most powerful, and we would expect that something like that would likely result in much stricter restrictions throughout the Peace Health system.
I would imagine our League of Women Voters lobby team are watching these situations very closely. Jeff, did you want to comment?
No.
Okay. If a physician is in private practice, can he or she get hospital privileges at a Catholic hospital without signing to follow the bishop's directives?
And I think it's a circumstance, Monica may know better than I think it's a circumstance that varies, at the moment, varies from institution to institution. There are, I believe, some Catholic healthcare organizations that require all of their employees to follow the clinical and ethical directives. And if they employ a physician, that means that physician is going to be required to follow the directives. What happens if the doctor doesn't follow the directions? I have no idea. But I think that the expectation for some of them is you're signing on as an employee, you agree as an employee to follow the values. I'm not certain that that's the case across the board.
Yeah, right now it's varied, but there's a trend. But yes, there are many situations where in order to get privileges, doctors have to agree to either the total set of ethical and religious directives, which I think applies in the Franciscan network, and with the Peace Health network, I believe the Statement of Common Values applies. But we're hearing different things from the physicians about the degrees in different institutions.
As a follow-up question on that, are either of you familiar with any other healthcare systems run by other religious organizations other than the Catholic Church who have contracts? And if so, what do they require of the physicians who practice with them within their system?
In general, any physician that wants to admit to a hospital is going to be subject to the medical staff guidelines that that hospital and its medical staff have determined are appropriate for their operation. So in almost every case, a physician that wants to admit to the hospital is going to be required to be a member of the medical staff, and in agreeing to be a member of the medical staff, they agree to the guidelines. As I said earlier, I'm not aware of any of the other religiously based hospital systems or healthcare systems that have documents that are as refined or as comprehensive as the Catholic directives are. They may well exist, but I'm not aware of them. Monica, do you know?
As far as I know, there are some institutions that have restrictions on specific procedures, but again, none of these, and the Jewish hospitals are actually tend to be quite flexible, and they tend to run a lot of hospitals, particularly on the East Coast. But there's nobody, really the Catholic systems are the big religious systems here on the West Coast.
Jeff, when a hospital district contracts with a hospital, do the taxpayer dollars go to the general fund or for specific services?
Depends on the circumstance and the nature of the agreement. I think there are some circumstances where public hospital districts are contracting for particular services, whether it's with a Catholic organization or a secular healthcare organization. Emergency room doctors is a pretty good example. There are a lot of hospital districts in the state that are now contracting for emergency room physician services because they can't attract docs to the community who want to work in the emergency department, so they contract out for those. So that would be an example of public dollars potentially going for a specific purpose. As I said earlier, I'm not altogether clear on all of the contracts that hospital districts have entered into, but I would be surprised, again, if there were very many of them that weren't pretty clear about what happened to public money. I could be wrong, but...
Makes sense. This questioner heard a comment that Catholic healthcare charges more. How is that documented? And isn't the issue the price of hospital-based care versus doctor office-based care?
So I am the person who said that the charges that we've seen in many Catholic institutions is actually quite high. There are actually state charts that document all of this. So for example, for deliveries, I don't have the figures, I wish I brought them with me, but I can certainly get them to you, of actual deliveries here in the state and what they cost at different institutions. And it was noticeably higher in some of the Catholic institutions, particularly here in northern Washington. So, and I think people here can just look at, I think there's an issue of what do people do because it's a religious hospital, and then what do they do just because the circumstances in the ways that we're organizing our care result in higher prices. So I think, like with this hospital, people have noticed that the prices are higher than they were at Inter-Island Medical Center. I know Bill Williams has documented that. You know, what are the reasons behind that? There's a variety of reasons, but I think that total cost and what was going to happen to, you know, to the patients, what the prices were going to be, was an important part of the conversation that the communities around the state should have as they're making these decisions.
I just note quickly in response to that, I
You
think
can
that
remain standing because my next question is for you.
the issues around what does hospital care cost and how much do we pay for it and how much do I pay for the care that I get and can I know that ahead of time? Many voices for many years have said we need consumers to be smarter about the way they use their healthcare dollars. Over the course of the past 5 or 8 or 10 years, almost all of you who have had employer insurance have seen deductibles and co-pays going up higher and higher. And so as a natural event then, you want to know, well, I want to be a good shopper. How can I figure out where to buy? Well, you want to know two things. The people any good at what they're doing? That's an important one. And then part two, how much is it going to cost me compared to people who are just as good? Turns out both of those things are really hard to find out, whether it's a Catholic institution or not. And so there's a lot of interest in Olympia in trying to figure out what we can do to make the cost of care more transparent, make it easier for people to understand how much is it actually going to cost me to have a procedure done at this facility compared to that one, and what confidence can I have that these people are any good at what they do? Or you've got another question you
I
want
do.
to answer.
How can you expect physicians employed by a Catholic hospital to stand up for their patients' access to services restricted by the bishops?
In the same way that I fully expect that the Catholic healthcare systems are going to stand by their ethical guidelines and directives. When we credential a physician, when we credential a nurse, when they adopt their personal code of ethics and their personal statement of values, their commitment to the patient's welfare is job one. To the degree that they compromise on that value, they have failed their professional obligation, in my opinion.
Jeff, what public process, votes or whatever, should be followed before a hospital district aligns with a public hospital?
I think this is a good question. Right now, the guidelines for public hospital district commissioners are pretty vague here. There's no established formal process. There's very little in state law. There's very little that describes what public hospital district boards ought to do. Now, my experience is that in most cases with an important decision, most public hospital district boards, particularly if it's a decision that's going to involve the use of property tax dollars, most public hospital district boards will go through a pretty public process. They'll try and make sure that there are public forums. They'll try and make sure that those forums are as widely publicized as the public hospital district's regular meetings are, at least, sometimes more publicized than that. But a great deal depends on a community that's paying attention and a community that's willing to show up and make itself known and make itself heard. And, you know, when Yogi's got a lot of great stuff to say, Yogi Berra. I'm getting to where I have to say both his names now. When I was younger, I didn't worry about that. Yogi Berra's got a lot of great sayings. One of my favorite ones is, if people don't want to go to the ballpark, there's no way to stop them. You cannot get people interested in an issue until they're interested. And try as you might to try and engage people in a theoretical conversation about what might happen, it's hard to do it until they feel like they have skin in the game, until they feel like they have something at risk. And I think in conversations like this one, and whether it is in this particular community or other communities, I think in general, most communities to date have said, there's a large Catholic organization that wants to come in and support our hospital. This is good news. I've been trying to figure out what's going to happen there. I'm worried about the quality of care. I've been to those hospitals downtown. Those are good hospitals. I think those people are going to do a good job. I'm happy to have them here. Now we see the other side of that discussion. As we find out that there are concerns to be had about what kind of limitations is that arrangement going to bring to the clinical people who practice in my community. And I think there will be fewer communities who find themselves down the road without this being a really important topic of conversation before an agreement is reached. How's that going to color these agreements? What's that going to mean to access to care? What happens if the Catholic organizations decide that working with these public hospital districts is just more trouble than it's worth? We were trying to be good guys and make sure that the people out there in the middle of nowhere had access to health care. I don't know how all that's going to play out. I will tell you that there are a lot of rural public hospital districts in the state of Washington who are challenged. I've got 6 that I expect are going to go into bankruptcy next year. Now, what happens as they go through bankruptcy, what's left when they come out the other side, we'll have to wait and see. But access to care in rural communities is really challenged. We don't have enough doctors, we don't have enough nurses, we don't have enough people living in those communities to really support a medical delivery system. This is all off topic, I apologize. But access to care in rural communities is at real risk. And how we address the issues around limitations on clinical practice as we try and bring and ensure that people have access to essential services is tricky. This woman right here is trying to get your attention.
I think we want to keep this away from Peace Island, but there have been many issues raised here. And I think it's worth noting that there were many public meetings offered before our new hospital was brought into being. I attended some of them, and there weren't very many others there. And there was a public outreach, there was public information available, but I think your point, Jeff, is terribly important, that until there is skin in the game, people don't pay attention. But I think we cannot be critical of our hospital board or the community foundation or the group that put together this deal, saying that they did not have the information out there. That's simply not true. David, which issues being raised here add to a case regarding the constitutional issues?
Sorry, can you add, what was the question?
The issues that have been raised in the discussion so far between the panelists and your remarks, how will they add to a case regarding the any constitutional challenge?
Sarah, there's a lot of background talking by you.
Yeah, could we ask that people keep their conversations to the back room, please?
I'm tempted to speak personally rather than for what I know our lawyers would want me to say.
Go for it.
So
You're informed on the issue and you have carte blanche, you're among friends.
I understand that there is a real conflict as
Jeff or Monica?
as Jeff just said. And I think that that conflict is between having a service and maybe not having a service, or having a service that has these restrictions. So it's hard for me to say what a community ought to do. But personally, it just seems to me that the whole idea of having religious institutions involved with any kind of public health system is, well, let's just put, it's tiptoeing on a line of something that I would think has very serious constitutional issues. Now, what our lawyers have told me is that they don't think there's an issue unless somehow services are affected. But every time I read anything about these agreements, I can't fail to see that if services aren't affected, they're only affected because they're not being provided when they ought to be. You know what I mean? They're just not there. So my own personal opinion is that it's constitutionally hard, in my opinion, to justify some of these arrangements. On the other hand, it's morally hard for me to justify saying someone won't get any health services at all if that's the alternative. So that I think is the issue.
One thing I struggle with, Sarah, is that we don't know what our healthcare system would look like without, if we enforce the Constitution, because it hasn't been enforced. And so, for example, when I have conversations with the University of Washington about what they might do around the state, they're looking at very aggressive, cash-rich institutions that they compete with. So there was a fierce competition for the, for the 3-hospital deal over in the Skagit area. UW wanted that business, and Virginia Mason wanted that business. And so, even when there's fierce competition, the Catholic systems are coming in with heavy resources. And I think the way that they model out how that business deal is going to work is there's a lot of money up front, And this is a personal opinion, but I think it's part of their business model to come in with a bunch of cash up front, but also to raise the prices for services. So it's just a business model.
Jeff, do you have any comments?
No, just quickly in relation to the last point, again, I think lots of concern in Olympia about the appearance of monopolies. And as we watch the healthcare system in our state increasingly dominated by one or two or three or four entities, there are a growing number of people in state government, legislature, and in the executive branch who are really concerned about the implications of that in what is supposed to be a marketplace. You know, you start to lose, you get down to where you've only got 3 or 4 sellers, concerns about what it's going to cost go up.
And this brings us to Cynthia, which is, what do you know is coming up in the legislative session, about this?
Well, I'm not sure what exactly is going to come up. I know of several legislators who are looking at this case, among others, and trying to figure out what they can and can't do legislatively. And what I was going to say is not in response to the constitutional question, but rather a response to the economic situation here. We have a healthcare system that has never functioned quite right. And what we're struggling with now is how do we make it right? And that's what the Affordable Care Act was trying to do. That's what our state insurance commissioner and that whole system is trying to do. One of the models that has been used extensively as a model has been group health, and that's provided some of the foundations for some of the system changes that are actually going to save money. So all of this system is in turmoil right now, and so I think legislatively, the state legislature for sure is trying to figure out, you know, what can they do and what should they not do at this point in time, knowing how much change is going on. How to fix something while it's in progress and not mess it up. So I can't really answer that question. I just know that there will be legislation. I just don't know exactly what it will be, and we're certainly going to be working on it. But the League has taken a pretty strong position about single-payer health care, and I think that form of a system will change some of these dynamics significantly. It's probably not the right time to bring it up, but we are talking about it. So just, it's a system issue, it's all over. And I don't think I answered your question, but.
Jeff? Jeff?
What would you see coming? What's going to happen? Do you see anything coming in Olympia?
What I know is that there are lots of people who are looking at an array of ways to approach this problem. We've got the rulemaking that's happening right now through the Department of Health process. And I encourage people to take a look at the draft rules that
Up to us. All right, next question. The writer wants a clarification. It says, he's quoting, OBGYN docs will not get paid if they do a procedure prohibited by the Catholic Church. The person would like that statement to be expanded upon. Who said that? Was that?
I think what I heard was that physicians may not be allowed by their employer to provide a service. And so read me the question again.
OBGYN docs will not get paid if they do a procedure prohibited by the Catholic Church. So this was in reference to a Catholic-based organization.
I think it's just a misstatement of the situation. Basically, the real issue is that these physicians are often employed by these entities, and they agree to abide by the rules of their employer, and so they can be fired. And there is also the issue of malpractice coverage. Because if you're a physician, the idea that you're making a tough call on whether a woman, whether her pregnancy needs to be terminated or not, and you make a call that somebody disagrees with and somehow there's a liability claim there, knowing that your employer might decide not to cover you for that incident, that's really scary. So there's a chilling effect that's going on with physicians. And again, I was just in a meeting with physicians from the UW, from many of these Catholic organizations who support their right and women's rights to have access to these procedures, but frankly, they're running scared. And they want us to work towards solutions where they can provide the best medical care possible to patients.
Another clarification, doesn't public money also include Medicare and Medicaid payments?
Yes.
Yeah. And Jeff, what role does a hospital district play? Just lobbying, or what other sorts of functions?
Okay, so I'm gonna think that question is really asking me about the Association of Public Hospital Districts. I'll speak for a minute about public hospital districts, which is what the question was. So public hospital districts are local governments. They operate under the Municipal Corporations Act in the state of Washington. They've been around for a long time. When Warren Magnuson was a new state U.S. Senator, he helped create the Hill-Burton Law, which was used to build thousands of hospitals across America. A whole bunch of hospitals in Washington state got built. One of the things you had to demonstrate was local commitment to support the hospital. Public hospital district statute was created to let local communities meet that federal obligation so they get federal money for their hospital. Public hospital districts have broad authorization under the law to serve a wide range of health services to their community, but the responsibilities, as I said before, are pretty vague. So what specifically does a hospital district commission or commission set of commissioners have to do under the law? They have to figure that out on their own. There isn't much direction there. One thing that is also sort of a quick note about public hospital districts, they can't make rules. So you can pass a county ordinance that says, we're not going to sell tobaccos at gas stations anymore. Or we're not going to have our liquor stores open on Sunday. The counties could do that. Whether they would or not is another question. Public hospital districts don't have rulemaking authority like that. They are creatures of county and state government when it comes to how are they going to behave. They can't make their own rules. With regard to the association, we do representation and advocacy work. We also do a fair amount of commissioner education. We've got a great website, awphd.org, the Association of Washington Public Hospital Districts, awphd.org. Invite you to look. You can find contact information. I also have a few cards up here. I sort of seriously underestimated how many people might want to work, so I'm sorry about that. But it sounds as if there's going to be lots of ways to find us when this is over, and I'd encourage you to do that. Thank you.
All right, this is going to be our last question, and for those of you who did not hear your questions asked specifically, to the best of my ability, I tried to coordinate questions which were similar, or collate rather, and I apologize if your question wasn't asked specifically. I suspect that our panelists will be around for a few minutes while we're cleaning up, and perhaps you can speak with them directly. The last question is, what if a Peace Health hospital sends a letter to a bishop stating that the majority of the physicians and medical staff of this hospital have decided not to follow bishop's directives? What could be the possible consequences for the hospital? This is citizen activism.
I'd love to read that letter.
All right, I want to thank our panelists for coming here today. And their willingness to bend with our few rules for today's presentation. Thank you for coming.